All right, team, welcome back to Plastic Surgery Untold, the greatest podcast in America, as voted by us. I'm Dr. Johnny Franco, also known as Austin Plastic Surgeon. We got our celebrity crew back, and back from the beyond, one Fernando Rodriguez rejoining us, I would say by popular demand, but I don't know that there were actually any requests. But he's here anyway, so boom, 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 there we are. So today we're going to be talking about breast reduction. Something that I think Fernando knows very little about, but hopefully we can still educate all of you about this a little bit. So should have some fun here. So let's get caught up with what everybody's doing since our last episode, and then we'll get the ball rolling here. Maybe I'll start off with Gilberto and Fernando, and why I'm rousing Fernando a little bit is they actually went out for a nice steak dinner last night across the street from my house while I was working hard. And do you think anybody got a doggy bag, any leftovers takeout? Nope, nothing at all. But
Ouch.
Gilberto, please explain your reasoning behind this.
Well, I thought we did get you a doggy bag. I sent it home with Fernando, but I went home on my own, so I don't know where it ended up. Maybe Fernando's refrigerator?
Yeah,
That's
where
interesting.
that's where it ended up at, and I was gonna bring it to you this morning. I didn't have a key to your apartment, so I couldn't leave it there for you. So it just made it home instead of your home.
Okay, I'm glad you guys thought about me. I appreciate
We
that.
always think about you. You're the topic of conversation the whole
Oh
night.
man, my BS meter was just off the charts when I was listening to that.
It's getting a little deep in
It
here.
is getting deep.
What's
in
going
here.
on with you, celebrity? I don't know that I should be the one to break this news to everybody, but word on the street is that you closed on a new house.
So we have not. Incorrect.
Damn, the rumor mill is not true.
We got to fact check that one. So we have not closed on the new house, but yesterday we closed on the sale of our old home. So that was exciting. Now we have it leased back for the next 20 days, and hopefully
Nothing better than selling a house and then having to pay to live back.
That's
right?
exactly right.
I mean,
in the same one. Gotta love it.
Okay, no, that's cool.
Yeah. So then
Seems anticlimactic.
hopefully in the next week or two, we actually close on the new house, which would be awesome. We're excited about that. So Mary's been having a lot of fun at Your Trendy Therapist. Give her a follow.
Who we actually invited on this show and decided that she needed to go shopping instead.
got to outfit the new house, man.
Okay.
We priorities. But yeah, we're trying to pick out a bunch of stuff for the new house and get everything situated.
So there's a little bit of a chance that you guys might be living on my couch. You two and
We
Winston.
we may if it gets pushed back anymore.
Okay.
I don't know. Winston may have some words about somebody sleeping on his couch.
Fernando, what's going on with you? Catch us up on your life. I feel like it's been a long time since we've had you on the show.
Well, actually, not a lot going on. Still sheltering at home. So my office went from my spare bedroom, so we converted that. And other than working hard, it's just same old.
Oh, really?
Nothing to write home about.
You've been working hard?
Yeah, most of the
Okay,
time.
That's interesting.
Most of the time.
All I can say is I think you can still get paid on time, don't you? So-
Gilberto, what about you? What's going on in your life?
So I just got back from a education course. I think I mentioned at one of our last podcasts I was going to be traveling to Kansas City to go do this really cool, really interesting cadaver course where we learn how to do injectables, more advanced techniques, and then we use these cadavers to inject, and then we dissect the cadavers to kind of see where our placement of filler was and make sure that everything is in the right place and make sure that we're avoiding any blood vessels and dangerous areas just for safety of our patients, and just trying to make our skills, just hone our skills a little bit better.
This is what impresses me. Here's Austin's greatest injector, and here he is just chipping away. I mean, I might be biased about you being the greatest injector, and maybe greatest injector was a little aggressive, but I would say you're at least top 1,000 in Austin. Top 1,000, I think we can all agree on.
I think that's fair.
Yeah.
That's a fair
Celebrity
assessment.
Fernando, can we agree?
He is at least one of the best guys in the room right now.
Yeah, at least top 5 of people on this podcast
Yes.
right now.
Right now.
Completely agree.
But I would probably
For those of you that are listening, there's only 4 of us here.
Yeah. and I would put him in the top 500, not in the top 1,000.
There you go.
Of
Yeah.
Austin.
Yeah,
Okay.
of Austin.
Okay.
Yeah,
Thank
right,
you,
yeah.
Fernando.
love it.
Thank you.
Good.
Yeah,
Because I think there's only like 550 injectors in the entire city. So.
Yeah, maybe 400. So
I-
who knows? But
I
he's in the
do
top
think-
500.
I do think it is really cool that you guys got to do the injections on the cadaver and then go in and dissect and see where that filler actually laid, though, because I mean, all jokes aside, that is a really cool thing to be able to do to see where you're actually hitting. And a lot of people don't understand that when you're injecting filler, it is completely blind. It's based on feel, it's
It
based on
is.
landmarks and technique, but it's cool to be able to go in and actually see where that landed.
Yeah.
And I actually think not to give away all of our trade secrets here, but I actually think 2 episodes from now we're actually talking about some more fillers, some injectables, and so maybe you can save a few of those nuggets
Yeah, absolutely.
for that episode because today we're talking about breasts. Can we get started?
Yeah.
Let's do
You
it.
guys
Let's
done
do it.
reminiscing
Yeah.
about your world travel?
Yeah.
Okay, let's do it. Let's talk about breast reduction. Breast reduction is an interesting topic because this is one of the standards of plastic surgery that's been around for years and years and years, and probably doesn't get some of the sexy hype that BBL, these 3D sculpting stuff gets. But I'll tell you, and celebrity sees a lot of these patients and stuff with me. Most of these patients, one, have thought about this for a long, long time. Two, they're one of the most happy patients because it's been such a big process. This isn't something they saw, an Instagram post from Austin Plastic Surgeon or one of the other great providers in town, and then decided to do it. That's something that's been contemplating for a long time because, from their standpoint, it's just something that causes a lot of restraints in daily activity. Would you agree with that, celebrity?
First thing I was going to say was these are some of the happiest patients I see immediately post-op. They're so excited to have this done. It's such a life-changing thing for them because like you alluded to, it has affected their ability to run and work out, and they have some back pain related to. They feel like they're carrying a bunch of weight around that they would like removed and taken care of. So it is. I mean, these patients are pretty fired up when we're done.
It's an interesting idea because breast reduction is this big spectrum of stuff, and so there's different ways that people get to the plastic surgeon about this, and sometimes people don't even maybe at the initiation of this realize that that's their cause. Because I would say half of the people that get a breast reduction are coming because of true symptoms. Whether it be and hopefully Gilberto can jump in on some of this. Whether it can be skin irritation, people can get
Mhm.
rashes underneath their breast, and that can be treated medically, but only to some point. If you have a chronic irritation, you got to get rid of the irritating factor. Two, back pain, shoulder grooving. Just limit from activity because of the weight and size of some of them. So it's very very interesting how that comes about.
Yeah, I'd say like in my practice, we see a lot of patients that come in with rashes under the breast, and typically it's due to friction. It's skin rubbing on skin, and then when there is perspiration or sweat that accumulates under the breast. We live in Texas; it's hot here, so it can be. You can be at work and still be sweating, and just be sitting in a cubicle and still be sweating, and that sweat creates friction where in those creases of the skin, and it triggers a lot of irritation, inflammation, and then that is compounded by sometimes some like bacterial infections or yeast infections, and it just kind of makes the situation a whole lot more challenging to treat. So I think, yeah, breast reduction for those types of issues would be like a godsend for some of these women.
Okay. I agree, and it's interesting because not all breast reductions are created equal, and so just when we're talking about breast dogs, a 300 cc implant can look very different on one person versus another. Such as calf implants on Gilberto, Fernando, and Travis would look very different on each of those legs. I promise you this.
They look the best on me though.
Oh,
I
come
would
on.
disagree. It would look best on me.
But so with the breast reduction, the amount that we take out or change, varies from person to person, and so does the resolution of symptoms. And before we get into the actual surgery itself and the different fine points of that, I think it's important for people to realize, that's a spectrum of breasts in terms of this and how much tissue we take out, where we get to, and then what symptoms they get resolved. I try to be very clear with everybody in that I've never had a patient, I'm knocking on wood here, who hasn't had some improvement in their symptoms, back pain, shoulder grooving, those type of things after a breast reduction surgery, and just feeling like they're able to move better. I even get patients sometimes who the very next day at their post-op would be like, "Hey, I feel better." And some of it, maybe psychological, some of it may be the actual fact that they can stand up straight and they don't feel something pulling them down. But I also caution patients, especially my older patients, hey, sometimes you've had these large breasts for 20, 30, 40, 50 years, depending on their current age. And some of that damage that's been done won't undo it. And sometimes those nerve damages, and Travis can jump in about this, takes a long time to to really heal, and people get better and better from some of these symptoms for months, but never can promise people that 100% of those symptoms will go away. Sometimes there's other factors going into your back and shoulder pain. Sometimes that nerve damage has just been for a long time.
Sure. I mean, I would echo that 100%. I think, I wish that I had more to disagree with you on so we could really go head to head, but I don't. I mean, those symptoms are not going to improve overnight, like you alluded to before. That feeling of heaviness and being too heavy in the front and having some of that immediate weight relief, I think is one of those things that does come immediately as far as a resolution goes. But like you said, if there is chronic nerve damage or nerve irritation, or they have some issues with their spine and degenerative, disc issues, those things are going to take time to improve. Nerves are one of the slowest things in the body to heal and regenerate. So unfortunately, sometimes those things are not a quick fix.
And so let's jump into the meat and potatoes of breast reduction, i.e., that's for Gilbert and Fernando, who had a great night last night. Um, uh, Breast reduction surgery, I think one of the biggest myths that I want to clear up is a lot of times I'll have people saying, "Hey, can I get a breast reduction and a lift at the same time?" And I think this is true for most plastic surgeons. I don't want to speak for everybody in the world, but most breast reductions include a lift. And so, because part of the idea behind the breast reduction is not only removing tissue, but we want to reshape the breast. We want to get the breast in a good position, because I do think there is some mechanics to breast reductions as well. When they're very long and out there, it's hard to support. It's hard to fit in a bra. It's hard to get into a good spot. When they're up and high and tight and perky and perfect, as we like to say, then the mechanics are overall better. So I think it's a two-phase part for a breast reduction. There's the reduction of the actual tissue, and then once we've got it reduced, then it turns into like our standard breast lift, where now our focus is in shaping and getting the breast as perfect as possible.
And I think you've had a pretty good analogy in the past as far as reshaping the envelope to put that breast back into once you've removed some of that excess glandular, breast tissue, and then reshaping that envelope and putting that envelope back together neatly.
No, it's almost a little bit challenging, because I think breast reductions is one of the procedures that in plastic surgery residency training, especially in the world of aesthetics, cosmetics, is probably one of the harder ones to understand, because the key is the blood supply to the nipple, and so we want to keep
Mm.
that nipple pink and perfect and everything else. And the bigger the breast, if you think about it, the longer the tracks are to get that blood flow to the nipple, right? And so more careful you have to be. But obviously, the bigger the breast, the more tissue people typically want removed.
Right.
And so it becomes one of these, little challenges, if you will. And there's a lot of different ways to do breast reductions. And I'm sure celebrity, doing anesthesia for all the great plastic surgeons in Austin. Maybe not all of them, but most of them.
Well,
Um, I'm sure you see a ton of different methods, and and
sure.
and and what's kind of funny is there's a lot of different ways to get there, but in the end, a lot of the results look pretty similar.
That they absolutely do. As far as different techniques, what the incision actually looks like, the shape of the incision, what they do with the pedicle, which you alluded to before, which is basically that complex of the nerves and the tissue that track directly to the nipple. If I'm not speaking out of I don't want to get too far into your territory. That's not my area of expertise, but
When has celebrity ever been shy about sharing his expertise?
um, but yeah, I think the every guy in town and gal that I work with, they do variations of basically the same thing to get to a very similar endpoint. I think that's the easiest way I could say it.
And Dr. Franco, how difficult is it to make sure that the nipple is actually centered on the breast after it's been reduced?
I don't think that is a good question. And there's a couple things. One, I don't think getting it centered right at the time of surgery is the hard part. One is keeping that nipple alive, and that really depends on the size of the breast. And so, even how you do it, even how I do my breast reductions really depends on the actual size, the wish of the patient in terms of what they're hoping to achieve. And then, the one really key about breast reductions, and this is true with rhinoplasties and some other things, is you want to anticipate where the breast is going to go 6 months from now.
Mm.
And maybe that's what you're alluding to
Yeah.
here, because when we revise breast reductions, one of the complaints I get sometimes from patients is they don't have upper pole fullness, which we'll get to, and then two, sometimes the nipple actually rotates too high over time, and then the issue is that they have a hard time in bras and tank tops. So a lot of times when we position the nipple on a breast reduction, it'll be just a touch low, as I did with my voice right there. And then as the breast settles a little bit, that nipple rotates up. And I think Travis has seen that with some of our mastopexies and other stuff. It's just anticipating. I know we have a lot of great rhinoplasty surgeons, and they're always talking about, oh, we got to talk about how the skin's going to shrink over the next 6 months and all that's going to settle. And it's that, I think that's the true art of plastic surgery, is anticipating how the tissues are going to mold and settle down the road, because those are people who get good long-term results and not just great Instagram pictures at the time of the surgery.
Completely agree with that. I think the other really cool behind the scenes kind of deal, and I don't want to get too far into our behind the bovie segment, but one really cool thing that you get to see in surgery with these plastic surgeons is you see the true art form of plastic surgery kind of take hold. When they have
Well, thank
open,
you.
when you, yeah, well, I got to tip my hat when it's necessary, or when it's deserved, I guess.
Which
But
isn't often.
no, which is not often. But this one, I definitely have to tip my hat on this. When they open up that the breast and they open that envelope up, there's a bunch of tissue inside. And I guess the goal for these plastic surgeons is, and Johnny Franco in particular, is very meticulous on how and where he removes that tissue to get that size down to what that patient's goal is, while trying to keep that nipple areolar or complex alive, and perfused with blood and oxygen. So it's interesting to see them, and they'll take off some tissue, and then we'll weigh it, and then we'll take off some more tissue, and then we'll weigh it. And it's this slow, laborious process that people don't get to see behind the scenes.
It's not that slow, as celebrities
I
pointing
didn't-
out there.
Okay, it's not that slow, but it's not just walking into the room, taking a knife and cutting like a big piece of skin off, and you're done. It really is, shaping a breast in his mind before he actually tacks that thing back together 100%. It's very cool to see that happen, and then get to the finished product. You're like, man, that was actually pretty neat. I don't think I could have done that after a couple YouTube videos.
What's the old saying? It's not what you take away, it's what you leave behind.
That's exactly right.
I mean, G. Berto says that to his ladies all the time. I'm not really sure what that means, but who knows? Little
But-
love note on the counter, something. Who knows?
to piggyback on what Travis was saying, I've assisted you in a few of these procedures early on in our careers together.
And when you were assisting me, it was not a slow process.
It was not a slow process.
Good,
Yeah,
good.
it was a properly paced
Yes.
process.
That was efficiently and properly performed.
Yes,
Thank you.
and it always blew my mind, like, just knowing exactly where to take the tissue from. Like, how do you know exactly where to take it from, superiorly, inferiorly, medially? It's really interesting to see.
And I think that one of the hard parts of the breast reduction, and to not make this super slow and last like for 16 hours, is trying to get people even. Because
Yeah.
when people are very off, I think people don't realize that's what's really, really hard.
Sure.
Because you can look at a breast and see them, like, in your mind, you have to have an idea of how much tissue am I going to take to make this even or not. And I think that's the true art and gift of plastic surgery, is
Absolutely.
having a feeling of like, okay, and to your point, you want them to not only be the same volume overall, but the same shape. And how do you take two completely different breasts?
Yeah, because
and
nothing's
try-
symmetrical.
Yeah, that's kind of the trick.
Yeah,
It blows my mind. I mean, we'll sit a patient up, as we're starting the case, and they may have one much larger pendulous long breast, and then the other one is wide and not as big. And to see you kind of, and your plan of attack, and the different guys and gals that I work with in town, it truly is. It is like watching art. I would not be able to do it, and I think it's one of those things where only a trained hand and trained eye, having done hundreds of these, would get to the point where you feel comfortable kind of making those decisions and moving forward.
Can we talk a little bit? Because some of the questions I get is how much tissue you're going to remove. And
Sure.
we've alluded to a little bit of this. Some of it's dictated on what the patient goals are. We definitely have patients that want to be really, really small. There's patients who still want to keep some fullness, but want to be smaller, perkier, that we can do. And this is where I love wish pictures, because it gives me an idea of what their actual goal is. Because with the reduction, there's not really a way to size people per se like we do with breast dogs. And so gives me a good idea that one, what we can do is attainable. Because as we've talked about here, there's a limit to how much tissue we can take out to protect that nipple, those nerves to that nipple, and those type of things. So I think that that's really important. Sometimes when you have very asymmetrical breasts, there's a limit to where we can get them because we got to find a happy medium of making them as symmetrical as possible. So there's typically one breast that's the limiting factor. Just like on this podcast, sometimes there's one guest that's the limiting factor. Um, but we aren't going to mention any names or point any fingers at somebody that's got a full belly from last night. But we'll keep moving on. So I think that's super important in terms of that. Also, some breast reductions can actually be covered by insurance. That's become a much more I want to
Common?
be
Difficult.
complicated, difficult, tedious path or course, I guess you'd say. Some insurance plans have written it out of their plans. Certain criteria often has to be met to fit that. So, in general, has become much harder than it once was. So, something to at least ask your provider about if they accept insurance, if that's something they can do. And then just remember, just because you have insurance doesn't mean that it's a service that's covered, but it's always worth at least asking the question. um other parts of the breast reduction stuff, because sometimes if it's an insurance thing, there's a certain number. They have a whole calculation of, they decide how much you have to take out to get covered, and that's a discussion for a different day about those numbers and how they come up with that. But again, just like breast dogs, one number doesn't kind of fit all, if that
No,
makes sense.
not at all.
Would you say that your practice does more of these breast reductions from an aesthetic perspective or a medical perspective or combination of both? Or
Our practice at this point doesn't, we don't directly accept any insurance at this point. So patients, if they're going to our practice and want to go through insurance, one, we'll either happy to refer them to one of the incredible plastic surgeons here in town that does accept insurance, or patients can actually file on their own accord and we can help them with that. I would say the vast majority of ours are aesthetic
yeah,
patients, either patients who don't have it in their plan, got denied, or just want to come see Celebrity Anesthesia. So
who
either
wouldn't
one.
want to
Thank
see
you, Celebrity.
celebrity?
It's funny because we had a patient the other day that was disappointed the
Oh
Celebrity had his
God.
shirt on during anesthesia, and I was like, it's kind of a sterility thing. Sorry, you just
Yeah.
gotta
I
keep it
I
on.
told her it was in the hospital bylaws. That's what
Uh,
I get in trouble for that.
but the other part is the incisions, because one of the things that I get all the time is, can we do the incision that just goes around the areola and not the anchor that goes down and the T underneath in a breast reduction? I would say 99% of the time the answer is no.
Yeah.
Because when we're taking out that much tissue, we got to get rid of the skin envelope too, because we want you to be perky and perfect. And if we take out a lot of tissue but don't get rid of the skin, you're still going to have that pendulous breast. And that's why it's very rare that we do liposuction, do things like that, where we're just removing mass effect and not removing the skin. Because most of the time, people, when they have extremely large breasts, tend to have ptotic breasts as well, because that excess weight has pulled the breast down over time.
Yeah.
Totally agree.
Gravity is just a bear, isn't it?
Some other common questions I want to touch base with, and guys, feel free to fire away questions at any point. Is one of the big things that we get is nipple sensitivity after breast reductions.
Sure.
How is that affected?
Well, I'm glad you asked, Gilbert. I'm glad you asked. With a breast reduction, 70% of patients end up back at baseline. 15% of the patients end up with some nipple hypersensitivity, and some end up with some sensation loss. The one thing with people who have very, very big, large breasts is sometimes those nipple sensations are already decreased ahead of time. So, if they've already had some nipple sensation decrease, that's likely not going to get better over time. And that comes from those nerves being stretched over time. And again, to what Celebrity talked about earlier, is just kind of the chronic damage to those nerves that sometimes can take a long time to heal, or may not completely come back.
Is there any concern about nursing or breastfeeding after having had
You stole my
Well,
question.
that's a great question, Gilberto.
took my
That is a
question
great
too.
question. The answer is yes, from several regards, and depends again on the breast reduction type. The I think most people think that the nipple, because we're moving it, actually comes off the breast. That's actually very, very rare. There is one type of breast reduction called a free nipple graft breast reduction, which we do extraordinarily rarely, and tends to be in people with just massive breasts that want to be smaller, and typically much older patients who are past the point of breastfeeding. But in general, the nipple stays attached to the breast, so those ducts, in theory, are still in a good position. A lot of times, there's two parts to this. One, a certain percentage of people can't breastfeed even if they've never had surgery. So
Mm.
if you've never breastfed before, you don't know if you're in that category. Two, sometimes what typically keeps you from being able to breastfeed actually becomes the nipple sensitivity. So people are hypersensitive. It just from a physical standpoint of tolerability, they struggle with that.
Okay.
Great question,
Yeah.
Gilberto.
Thank you.
We're waiting for Fernando to drop us a nugget, but until he does, I'll
And
keep rolling.
yeah, and what does the scarring look like around the nipple itself?
What? That's a great question, Fernando. The incisions do tend to vary. So, one, I think some of the points you're bringing up around the areola nipple, because that tends to be a huge focus on breast reductions, is most of the time with the whole breast being stretched and large, the areola and nipple tend to be very large. And so most of the time we'll bring it down into a smaller size. And we have what we call cookie cutters, but they're basically areola sizers that are different sizes. So we can make sure that areola matches the size of the new breast. Because if the breast is smaller, perky, or perfect, then we want the areola to be perky and perfect and round too.
Mhm.
And what happens with that is we do try to put the incisions right around the border of the areola where people have a natural change, and so that hides pretty well. And then the incision down the front, and then some variable in the T. There are versions of, I think celebrities seen some of these other versions of breast reductions where you can limit the scarring to just around the areola and down the front of the breast. Some do kind of a lazy S where it's down and then just out laterally. Again, depends on the size of the breast, the amount of tissue taking, and then the person performing the surgery. Again, there's no necessarily one that's better than the other per se. Just depends on the situation.
And does skin tone have any
Absolutely,
effect?
absolutely. People with darker skin, we tend to have to be a little bit more careful with scarring. But just because you're fair skin doesn't mean that you can't scar poorly. So I think it's super important to take it very serious. There's lots of things we do to try and make it the scarring and healing as good as possible. Lots of sutures on the inside, using the dissolvable sutures so they don't irritate the body long term. A glue over the top, which has been shown to decrease scarring. And then I do love the silicone cream or sheeting
Mm.
afterwards to make sure people are in a great spot to help with that. And every provider has a different kind of scar management procedure because it has to go in rhythm with what everything else they're doing, right? If you're using the glue, you don't want to do it till after the glue comes off. I think some people like to do these steri-ship, other stuff that they like to keep on for several weeks and then remove everything. So there's a lot of good methods, but it's got to fit in protocol. So make sure you talk to your physician about that. But that's a great something to remind people, Fernando, about stuff, something they should have, a conversation they should have with their provider.
And you're not using super glue, right? Like they do on the YouTube videos?
It's basically like medical grade super glue. So somebody
Okay.
sterilized super glue, it charged a fortune for it, and then made it purple, and boom, boom, boom. They're
There's your
they're on their
Dermabond.
yacht being like, man, I love that people are using crazy glue for
Right.
surgery.
Okay.
But that's not the only thing holding them together.
Yeah,
I
yeah.
promise we do spend some time suturing you back together.
Do you ever run into issues with
On the yacht? No.
which issues with like keloids in the areola complex or in these breast reductions?
Keloids right around the areola are very rare, but
Yeah.
to your point, they're not zero. They're
Yeah.
not zero. And so, we take it very serious, especially if people have keloids in other areas.
Yeah.
There's different reasons that people get keloids, and that's maybe a good topic for another
Sure.
day.
Yeah, yeah.
As I feel like it's a very complex
It's a very complex topic.
situation with
Yeah.
lots of different treatments. I think if you've had poor scarring, definitely make sure that you bring it up to your surgeon ahead of time so that you guys can have a realistic idea about what your results could look like. I think also so you have a plan to treat them if they do come back. There's ways to minimize this, but there's no Gilbert, if you know a magic treatment, I'd love to hear it, but there's no way to 100%
No.
guarantee that they won't come back or that you won't get them.
Yeah. Yeah. I see them a lot in like ears and
Mhm.
different parts like back and stuff from like acne. I just wasn't familiar with what the probability was in some of these other surgeries. If you run into that at all or have heard of anything like it.
I've seen it. It's definitely tough to to treat if they get it. And that's why typically trying to look at other scars and see
Mhm.
where if they've had a C-section, how did that heal, other
Yeah.
things like that. As you know, there's definitely areas of the body. Unfortunately, breast is not as prone to keloids as arms. I mean, as earlobes, deltoids, center of the chest, and then back.
Yeah.
Typically, the thicker the skin, the higher the
Sure.
chance
Yeah.
of the scarring.
Yeah.
I think another cool little point, and we've talked about this in the past, and really getting on the same page with your provider and your plastic surgeon, like, hey, what are our options moving forward as far as scarring goes, and what are you thinking as far as incisions go? And then if you want to, you could use something like Real Self or the different websites for those providers and see before and after. Try to find somebody with your skin tone or similar breast to kind of compare. Hey, maybe that's a give you a good idea. It's not going to be exactly right. It's not going to be perfect, but at least give you an idea of what those scars look like post-op.
And an idea of what the results you're hoping for,
Sure.
because there's some patients, and this is I think especially in the world of YouTube, Instagram, TikTok, LinkedIn, whatever you want to do, of sometimes some unrealistic expectations, because I have a lot of patients that want to do an augmentation at the same time of their breast reduction, and in a very small reduction that's not unreasonable. But in our patients that were doing a 700-800 cc gram or 700 or 800, that didn't make any sense at all. Sorry, guys. 700 or 800 gram reduction, to then turn around and put a 500 cc implant doesn't make a ton of sense. And that really, really puts us at risk for the nipple. And so
Sure.
sometimes we got to break these surgeries up into stages to make it super safe, because remember, it's all about the blood supply to that nipple. And if we're cutting around it, to the sides of it, and then we're going to cut underneath it, it doesn't take a lot of a lot of math there to see that we've really subtracted a lot of blood supply to that
Yeah.
nipple.
Absolutely.
And can you address how high blood sugar could affect scarring on a
Ooh,
person?
that's
Be-
a great question, because you're talking about glucose, diabetics, pre-diabetic,
Diabetics,
those
yep.
type of things.
Yeah,
Uh,
and there's a lot of people that don't know that they're pre-diabetic and maybe having issues with scarring, and you
Sure.
don't figure that out until you run the pre-labs on them.
I feel like you've hit on like 6 points here. You came in strong at the end here, Fernando.
It's making up for lost time.
Yeah, because to your point, we do labs on everybody ahead of time, and probably once a year when we're doing these labs ahead of time. And you can refer to episode 17 if anybody would like to listen to pre-op podcast stuff. But we do pre-op evaluations on everybody, and probably once a year we find somebody who's an undiagnosed diabetic. So basically what you're saying, Fernando, that their sugars are high, they didn't know it, because sometimes when it's a gradual increase, you don't feel a sudden change, and sometimes they may be a little tired, little something, and don't even know where that's from. So good point there. And if that's the case, then we tend to just reschedule their surgery. We do have a hemoglobin A1C cutoff. Dr. Chang actually talked a lot about that, because that gives us a big picture of glucose. So 6.9 is our cutoff, trying to stay below that, because below that, people's wound healing is actually pretty close to baseline. So we do that. Um, uh, uh, the problem in what you're talking about, Fernando, and this is super, super important, is, you know, we're deconstructing the breast. It's
Mhm.
pretty amazing what the body will heal. We open up those flaps, we take all that tissue, we rearrange the breast, and then put it back together. But now, we put everything back together with sutures and holding it in place. But the body's got to take over. And to your point, if the glucoses aren't controlled, then the body won't take over. Things don't heal. Those sutures dissolve, and stuff starts to fall apart, or you're at risk for infection, poor healing, a hypertrophic scar. So I think that's super important. Yeah. On that note, just because you brought up such a great nugget, smoking. I can't
Yeah.
mention this enough times. Smoking is horrible. We're crazy about it. A month before, got to be offered for a breast reduction, because that's how you lose a nipple. That's how you get a big hole in your breast.
Yep. Completely agree. Every time I talk to patients pre-op, if they were smokers and they stop for surgery, I say, please, 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 please. It is not even about us not wanting you to smoke for the lung and health reasons related to smoking. We want this to heal properly. We want enough oxygen and blood supply to those tissues. And when you start to damage microvascular circulation with a high blood sugar load or with smoking, those things lead to poor wound healing and lead to making patients prone to infections at those surgical sites too.
Because I think some of the things that people forget, especially breast reductions, is one of the core plastic surgeries where we're really taking off the breast and kind of making these big flaps where the blood vessels got to go long ways. And so a lot of
Yep.
times people smoke, diabetic, maybe hypertensive, which is another
Yep.
one that leads to post-op bleeds, and that's been shown over a certain limit, especially facelifts, other stuff. A future topic of ours, they can have an elevated, blood pressure, and actually has been shown statistically to increase people for risk of bleed. True in
Absolutely.
breast reductions as well. But somebody may say, "Oh, I had a knee scope and I healed." It's not the same when
No.
you go straight down and there's not these big vessels that have to come all the
Mm,
way through. So I
yes.
think you got to compare apples and oranges. I know we're running a little short on time, so I just want to hit up recovery because I think this is a perfect transition about healing recovery.
Yep.
With breast reduction, really want to make sure people give themselves a chance to recover at least a week and a half to 2 weeks, depending on physical labor of your job. If you're a heavy lifter such as Celebrity and I are, if you're just living the good life like Gilbert and Fernando, I mean, sometimes you gotta, carry your own fork to the table, but other than that, it's a pretty easy life. Then you don't have to worry about it too much because we've had a lot of people working from home trying to get procedures done.
Sure.
I think working from home gives you a little bit more flexibility,
Yep.
but still got to be careful. I don't want people, even if it's Zoom, something else, working from home if you're taking pain pills can make you a little foggy. It's like working on a couple margaritas. Also, you don't want to limit the pushing pulling because you want those incisions to heal, as G. Berto, Austin's most beautiful man, stated. You got to make sure. That reminded me of a story that we'll come back to. But you want those incisions to heal as good as possible.
Yep. Anything that reduces tension on those suture lines is going to help you. So, we want you moving around and everything, and want you up and ambulating, post-operatively, so that you're reducing any risk of developing pneumonia or anything like that. But we don't want you doing push-ups. We don't want you raising your arms and moving your arms all around, because all that's doing is stretching on that. It's adding tension to that suture line.
So in terms of recovery, Dr. Franco, what can someone expect as far as like pain?
That's a great question, and people typically don't have the same pain with a breast reduction that they would a breast aug or something else because we're not messing with the muscles or bones, and that's what
Mm.
tends to cause more pain and discomfort. And so they do feel some burning at the decisions, but again, with breast reduction, most of the time they feel such a weight truly lifted off them that it's almost a wash because their back and other areas feel good. They're like, yeah, I feel some burning, but overall I'm pretty good. And then with some of the new techniques, and hopefully we'll transition right into this, but
Boom.
people don't feel so nauseous, don't feel so sick because of the ERAS and some of the other things that Celebrity and his team do to make the recovery a little bit easier.
Sure.
Can we talk about anesthesia a little bit to
Yeah.
take us down the home stretch
And,
here?
and I know we've touched on the ERAS protocol, that enhanced recovery after surgery, several times, and reducing our narcotic load on these patients and using some novel adjuncts as part of these anesthetic techniques to reduce pain and decrease this wind up phenomenon that's described in the literature. But and a lot of that's taken care of with preemptive analgesia, which is, Dr. Franco putting local at the site, local at the skin, us loading patients with gabapentin and other drugs preoperatively, so that they don't end up with this
Teamwork makes the dream.
that teamwork does make the dream work. Hopefully, here over the next couple of months, we're able to share a couple of new nuggets. Dr. Franco and I have been talking
We
a
may
little
be
bit.
getting a new Christmas
We
present.
may be getting a new Christmas present. And I don't want to, no spoiler alerts, but I'll hint at it. We may be exploring a couple of regional anesthesia
You just
techniques.
said you weren't going to
I
spoil it.
said I wasn't
You
going to
just said
spoil it,
that.
but I didn't give it all
and then
away.
you fold it with the spoiler.
I know. Okay, sorry. I'm excited about it, man. I'm excited.
Don't worry. Don't turn off your podcast. I'm not going to spoil it, but I'm just going to lead right into it.
I got excited, man. I'm like a kid on Christmas morning. No, so we
just
are
one present. You can just open just one present, Travis.
the one present. So yeah, we're hopefully going to be able to cover a bunch of stuff in the future and show you guys some techniques that we'll use with the regional anesthesia to pick off specific nerves that we can track from the spinal cord to decrease that sensation preoperatively or even intra-op, so that we're decreasing that stimulation along that nerve path before it even happens, which is very cool stuff. And we're hoping to reduce the amount of narcotics patients need and that feeling of pain completely in some of these cases. Very excited about it.
Wow.
Can you maybe touch a little bit on this? Because I think sometimes people get a little confused, and I am taking a selfie while I'm talking right now,
Boom.
so for the gram. But we talk about low narcotic and these local blocks, other stuff.
Sure.
But the goal of the narcotic stuff, and narcotics aren't bad in the right uses.
No,
so
not at
we're
all.
not saying that. If you need pain meds, you need pain meds in
Absolutely.
the right moderation. Like everything, it's fine. It has a good place. They're
Sure.
helpful. But what we're trying to do is you're trying to decrease how sick they feel afterwards. So that's part of what some of that overall post-op recovery is.
Sure. Yeah. And that's again with the myriad of meds that we give to patients preoperatively and intraoperatively. What we're trying to do is reduce the untoward effects or the bad side effects of narcotics that do come with those medications, the constipation, the dizziness, the that brain fog that people describe. Opioids are also not completely benign when it comes to pain, believe it or not. There have been several studies that actually show that the amount of narcotics you're given intra-op or during surgery and you take post-operatively can actually increase your pain with that case, and that's called hyperalgesia. That's a real documented phenomenon. So we're trying to do everything that we can to set patients up with a great post-op experience, reduce that nausea, reduce the constipation, and get them up and mobile and feeling more like themselves and feeling more lucid than you do when you're taking a large amount of narcotics post-operatively.
So you're saying a body in motion stays in motion?
Ooh,
Look at
Fernando,
you with the quote of the day. Maybe
I feel like somebody brought you a halftime coffee because you've come in strong. You've
Here
come
he
in strong.
goes.
The second half you've owned. It was like I was watching one of the football games this week, and they showed the team stats from the first half where they had scored like 7 points in the second half. They had scored like 42 in whatever the last 3 games. That's Fernando. He was asleep the first half, but he has come on strong.
He got a little pep
He
talk
has
or
come in
something.
strong. Huh?
He got a little pep talk or something.
He did. He did.
It's that
like,
steak from
damn.
last night kicking in.
Yeah. Well, let's can we jump into a little behind the bovie? I know we're running short on time, but we can't miss our favorite segments. And then I know Fernando threw in a couple of quotes already, but maybe Gilberto or Travis will have something to take us home with. Behind the bovie, Travis, anything you want to say? If not, I can throw in a nugget or two.
Well, I was gonna before you said it earlier, I was actually gonna tell him about the cookie cutter, the areolar nipple sizing ring that we use to determine the nipple areolar size, which is pretty cool. We spread the nipple wide and then place that on it, and you normally trace around it with a little marker, and then you cut along that line. That is a cool little technique, and hopefully maybe one of these days in the OR we can talk a little bit more about it and show some pictures and video on Instagram.
Well, I've tried to convince my team, and maybe we can do a poll of having an OnlyFans account. This way we can show those portions, because right now when I show those portions, I get put on timeout
By
Facebook and Instagram, and I get an Instagram that says, "Please take this time that we've suspended your account to review our safety guidelines." So
as it should be, Dr. Franco.
So
as it
we'll
should
have
be.
to look into some ways to show you those, because I think it is cool. I think the behind the bovie nugget I would reinforce, and we've talked a little bit about, is for the vast majority of breast reductions, breast lifts, OGs, the nipple never leaves the body. It's always attached. And I
Yes.
think because we can't show some of those portions on social media, I think it sometimes gets a little confusing how when we tailor tack people, there's no nipple, and then boom, at the end, it's back. It's just hidden underneath, but it's still attached to you, because that's what preserves those blood supplies to the nipple, those ducts for breastfeeding, and the nerves. So all of them run together.
Absolutely.
Can we get a quote of the day? Take us home strong.
Gilberto,
Yeah. So
Why are you mad dog staring at me right now?
no reason.
Okay.
don't let us down, man. Don't let us down.
No reason, just staring at you. Okay, looking into those eyes.
Yeah.
Continue.
Looking into the soul.
Yeah. Ooh, damn.
To kind of piggyback on Fernando's little quote of body in motion stays in motion, here's one from Albert Einstein. Says, life is like riding a bicycle. To keep your balance, you must keep moving.
I like that.
Okay.
Yes.
Okay. So what would you say you're moving right now? Like what's your biggest move right now?
My biggest move is coming up with better quotes.
Travis, biggest move in your life right now.
Moving our house.
That's a little one. Okay, cool. Fernando.
Learning more about internet technologies and how to make the systems work better.
Oh, so you're creating an OnlyFans account as well. Okay. Well, on that note, check him out at Fernando69*36. You're welcome.
I believe that's 21 to 39, please.
Well, everyone, I appreciate you guys tuning in to Plastic Surgery Untold, the greatest podcast in the world, as voted by us. Appreciate all of our guests. Appreciate Fernando rejoining us, coming back, and having a good time. So thank you guys. We'll see you guys later. Bye.
Good to
Bye.
see y'all. Have
See
a good
ya.
one. Bye.